Okay, so let's start with the top 10 sedation and analgesia papers. The core message is light sedation, analgesia first, avoid benzodiazepines, CAM-ICU daily, and mobilize early. So without further ado, Kress et al., New England Journal of Medicine, 2000, daily sedation interruption. So this is the paper that really changed everything. Daily awakening trials cut mechanical ventilation by 2.4 days, ICU stay by 3.5 days. So it ended the routine deep sedation. It was a single center Chicago study, 128 patients before this. Everybody was deeply, continuously sedated. And you can see the improvement, mechanical ventilation days, ICU length of stay, no increased PTSD, 1 year follow-up. Daily awakening did not traumatize patients. So that really ended the routine deep sedation. The next trial that you should know of is Gerard Lancet 2008 called the ABC trial. So paired spontaneous awakening trial and spontaneous breathing trial. The 1 year mortality was significantly improved in the daily awakening group. This is mechanical ventilated sedated ICU adults, 336 patients. Ventilator-free days were improved. 1 year mortality was improved. There were more self-extubations, 10% versus 4%, but there was no difference in the reintubation rate. So the ABC trial operationalized Kress into a paired protocol. So you had daily awakening trial, daily breathing trial became the A and B of the ABCDEF Bundle, which is the cornerstone of ICU Liberation. Okay, 1 year mortality improvement, 44% versus 55%. And remember, the A, assess and manage pain, and B, which is the spontaneous awakening trial and SBT of the ABCDEF Bundle. Number 3 is, I'm not going to try to pronounce the name, JAMA 2007 is called MENDS. This is PRODEX versus lorazepam. And this showed us that benzodiazepines causes delirium. So the dexmedetomidine, which is the PRODEX, it doubled the delirium-free days. You could see the delirium coma-free days, 7 versus 3 in the lorazepam group. This is surgical ICU and medical ICU, 106 patients. Mortality trended better in the dexmedetomidine group. Again, the p-value was 0.18, so it was only a trend. And the p-value of 0.01 up here is really for the delirium coma-free days. So you can't really say that it was better mortality-wise. But the big takeaway was benzodiazepines causes delirium, and you have a randomized controlled trial that actually proved it. And so the dexmedetomidine doubled the delirium coma-free days versus lorazepam, and the odds ratio per dose was 1.2 for delirium transition. Every benzo bolus independently increased the probability of going into delirium. So that's the routine benzo infusions in the year 2007 stopped. Then you have SEDCOM, which is the dexmedetomidine PRODEX versus Versed trial, JAMA 2009. Again, delirium decreased in the PRODEX versus Versed. The time to extubation was much shorter in the PRODEX. There's 375 patients in a mixed medical surgical ICU. Extubated faster. There was more significant bradycardia, 42% versus 20% in the midazolam. So, but it is the first randomized control. This is the first randomized control trial showing benzos cause delirium was the MENDS in 2007. This one is a replicated study now using midazolam. So it also shows another randomized controlled trial showing delirium rate much lower with PRODEX versus a benzodiazepine. The SEDCOM and MENDS were the two trial case against benzodiazepine delirium was 54% versus 77%. The extubation was faster. You should know the bradycardia risk. MIDEX and PRODEX, one of my favorite articles is JAMA 2012. MIDEX, it was two different things being looked at, Dex versus Versed and Dex versus Propofol. Mechanical ventilation duration was significantly less in the PRODEX group when it came to versus Versed, not necessarily versus Propofol. So that is interesting. But what I loved about this trial is it showed you hypotension was roughly 20% with the PRODEX and the Propofol, and it was roughly 10% in the Versed. Versed was better hemodynamic profile. The bradycardia in this was 20% in the PRODEX and Propofol, and it was 10% in the Versed. Did I say that right? No, I'm sorry. The bradycardia was 10% in the PRODEX and 5% in the Versed. So bradycardia was less in the Versed and hypotension was less in the Versed. However, mechanical ventilation duration was significantly less on the PRODEX. In terms of mechanical ventilation duration, Dex beats midazolam. And the patients can be aroused for communication while sedated. That was huge. SPICE 3 trials in New England Journal of Medicine now later, 2019. We have 3,900 patients, the largest sedation randomized controlled trial. It's PRODEX versus usual care. There was no mortality benefit if you used early PRODEX versus usual care, which was propofol or midazolam. So the 90-day mortality was neutral. The 63% of DEX patients needed supplemental propofol. Age greater than 65 showed perhaps a benefit in early dexmedetomidine. So what does it mean? So it reduced delirium, shortened mechanical ventilation versus benzos, but it does not reduce mortality versus propofol at scale. So you use the DEX when delirium prevention, cooperative sedation are the priorities, but use propofol when rapid depth titration and tight control are needed. DEX you shouldn't think of as a mortality drug. It's a delirium and quality of sedation drug. Okay, so it's no mortality benefit, and think of it more of a delirium reduction drug. New England Journal of Medicine, 2013. PANDA, let's just call it PANDA, the long-term cognitive outcomes, BRAIN-ICU, ICU Delirium, lasting brain damage. 34% of ICU survivors have TBI equivalent cognitive impairment at 1 year. This is 821 patients. The 3-month cognitive outcomes, 40% equivalent to moderate TBI, 26% equivalent to mild Alzheimer's disease. That's the 3-month. And at 12-month, it persisted. It wasn't transient. Patients did not recover by 1 year. So the 3-month cognitive score, each additional day of delirium independently worsened the 3-month cognitive function. And then this 12-month cognitive score, the effect persisted at 12 months. It was not attenuated. So really, BRAIN-ICU answers the so what. Why does preventing delirium matter? Because 34% of ICU survivors are walking around 1 year later with cognitive impairments, essentially like that of somebody with traumatic brain injury. So Kress, ABC, MENDS, PADIS matters, not just mechanical ventilation days, but also the brains. And let's see this. The next two trials to look at are the treating pain first trials, UltiSAFE and Strøm. So it's an analgosedation. Not sure how to pronounce that. Analgesia first, sedation second. we're looking at 208 patients in the UltiSAFE, and the Strøm trial was 140 patients. So we're looking at remifentanil versus conventional sedation. Mechanical ventilation duration was lower, ICU stay was lower, and the no sedation versus sedation and daily interruption, the Strøm showed also less mechanical ventilation days. So pain is a major driver of agitation, sedation requirement. You treat the pain first with short-acting remifentanil. The patient is comfortable, and less agitation, less sedation needed, lighter sedation. And we have analgesia first is a strong recommendation. You treat it and you cut the sedation requirements. In the UltiSAFE, it was 3.5 days less mechanical ventilation. In the Strøm, without using sedation, you were much less likely to be in the ICU, less days on mechanical ventilation. Zhang meta-analysis, so this really looks at 41 randomized controlled trials, Dex versus Propofol. It reduced delirium by 50% versus Propofol. There was no mortality benefit. There's 2 times the bradycardia risk, even though we saw the bradycardia in the MIDEX PRODEX was about the same at 10%. But anyway, let's look at mechanical ventilation duration. Dex is slightly shorter, significantly better when it comes to delirium by 50%. ICU length of stay, there was no difference. Bradycardia, looks like Propofol is actually safer. And then in terms of mortality, there was no benefit. So this is the largest meta-analysis looking at Dex versus Propofol. So you should know that the delirium goes down by 50%, but the bradycardia goes up by 2 times more. So think of Dex for delirium prevention and Propofol for rapid titration. So then you should know the guidelines, PADIS 2018 and 2025 update. So this is you should know light sedation first, target RASS -1 to 0. You should know analgesia before sedatives. Propofol Propofol or Dex more than benzodiazepines. See, benzos increase the delirium risk. CAM-ICU, strong recommendation, which is the delirium. So the 4 features of the CAM-ICU, which is acute onset, inattention, altered consciousness, and disorganized thinking. Those are the 4 features of the CAM-ICU. You should know the bundle, ABCDEF Bundle execution. And the 2025 update, anxiety is distinct from agitation, and Dex is preferred over Propofol when you have light sedation and delirium prevention are dual priorities. So higher ABCDEF bundle compliance, decreased hospital mortality. This is looking at 15,226 patients, fewer 7-day readmissions. So again, the highlights are light sedation, analgesia first, CAM-ICU, ABCDEF, and knowing that anxiety is a distinct domain, you should know these 6 recommendations pretty well. 4 more that you should know about: CAM-ICU validation, understanding what are the 4 features of the CAM-ICU that we just talked about: acute onset, fluctuation, inattention, altered consciousness. ABCDEF bundle implementation, PUN 2019, we touched upon this just on the last PADIS guidelines. SPICE 3 age subgroup. So we also went over that the dexmedetomidine might show benefit if you're greater than 65. And then dexmedetomidine in cardiac surgery. So there was a shorter ICU and hospital stay with Dex. So it might be the strongest mortality benefit. Overall, we went over the Kress trial, daily interruption, ABC trial, paired SAT and SBT, the MENDS trial showing that benzos cause delirium, and SEDCOM, again showing that Dex was better than midazolam this time. MENDS was versus lorazepam. MIDEX and PRODEX Dex beats midazolam in terms of mechanical ventilation. SPICE 3, there was no, if you used Dex versus Propofol, there was no mortality benefit. BRAIN-ICU shows that having delirium in the ICU hurts later on in terms of cognitive dysfunction. And then UltiSAFE and Strøm showing analgesia first. The meta-analysis showing that delirium goes down, but there was no mortality benefit. Bradycardia goes up. And you should know the 6 points of the PADIS guidelines.